Thank you for joining me. I'm Nicole Judice, a technical director for Palladium on USAID's Health Policy Plus project. I'm here today to bring you an energizing conversation with two leading health financing experts. They will share insights on the recently signed Kenya Health Financing Strategy, a comprehensive undertaking by the health sector that sets clear goals towards sustainable health financing and financial protection for Kenyans. The HP Plus project, funded by the United States Agency for International Development, works closely with the government of Kenya to advance health policy, finance, advocacy, and governance priorities. The project aims to strengthen the capacity of country partners to improve the enabling environment for equitable and sustainable health services, supplies, and delivery systems. One of the signature initiatives that HP Plus Kenya supported was the development and finalization of the Kenya Health Financing Strategy, signed on June 30th of this year by the Cabinet Secretary of the Ministry of Health. The strategy is a blueprint to guide the country towards achieving universal health coverage by strengthening health systems and attaining the highest possible standards of health for Kenyan citizens. Given the critical role that the Kenya Health Financing Strategy will play in providing equitable access to quality health services, it is important to understand the comprehensive process and efforts that went into its development. To share more on this, we are delighted to have Stephen Mushiri and David Hoya with us today. Stephen Mushiri is the former Program Director of HP Plus Kenya and East Africa Program. Before joining Health Policy Project in 2012, Stephen worked throughout Africa on health resource tracking and healthcare financing initiatives. He has served the government of Kenya in various capacities, including time with the Ministry of Economic Planning, the Ministry of Health, and the Office of the President, and has played key roles in several ministry central planning units. Stephen served as Chief Economist for the Ministry of Health, overseeing the Policy and Planning Division. He holds a bachelor's degree from the University of Nairobi and a master's degree in Health System Planning and Administration from the University of British Columbia in Canada. Dr. David Hoya is the Program Director for Health Policy Plus Kenya. David has a PhD in economics from the University of Cape Town in South Africa. Before joining HP Plus, David was a lecturer at the University of Nairobi and Strathmore University in Kenya, teaching health economics and statistics. David has also worked as a researcher in a public policy institute and as an economist and a planner in the pharmaceutical industry. It's great to have you both with us at this exciting time in Kenya. Let's get started. Mr. Mushiri, I'd like to start with you. Given your extensive background in Kenya's health sector, what broad health policy issues is the strategy responding to? And what does it mean for Kenya's ambitions to reach UHC by 2030?
Thank you, Nicole. The strategy normally covers three broad areas, and I will start with the first one, which is increasing access and equity to health. And the reason why this was an issue is because if you look at per capita utilization on health, is at about 2.5 visits per year, which is below the regional average of 4 visits per year. And secondly, 28% of the sick people never sought care when they were sick, and that was a big concern to health because of access issues. And finally, only 20% of the population have got insurance cover. So another reason why that issue of equity and access became important to the government to address in the strategy. The second issue is on mobilizing domestic resource for health. And I think although government has done pretty well in terms of mobilizing funding for health, we are talking about pre-devolution of 5.2% of the total government budget. We are now at 11.1% of total government budget, which is a commendable progress. But you still find 19% of the budget is externally funded. And while still, if you look at key programs like HIV/AIDS, over 60% of the funding comes from domestic external funding. So that's the reason why DRIM became important, so that we are able to develop a sustainable framework to support the health sector. And finally, it's efficiency issue. The third issue was efficiency. And efficiency is critical because you need to get value for money. I think WHO estimates that inefficiency in the health sector in Kenya is between 20 to 30%, primarily in two focus areas, HRH for health, or human resource for health, and pharmaceuticals. And I think we need to look at those two issues, ask ourselves, how can we improve efficiency and be able to get more value for money? Part of the work that we have been doing as HP plus HPP is on allocated efficiency, and I'd like David to share with us some work that we have done in the counties looking at allocated efficiency. David.
Thank you, Mr. Mushiri. I think this is a good opportunity for us to share what we have done in the counties. And part of the work we did in the counties, especially in the counties where we were given the mandate to operate, we actually supported counties to be able to appreciate how best to allocate resources. And we found some counties like Mombasa allocating much of their resources to human resources, labor ideally, and through the interventions we had by showing them the evidence, they were able to reprioritize and allocate more resources to commodities as opposed to labor alone. And that demonstrated some of the evidence we provided that informed their decision to reallocate resources to more other inputs as opposed to labor alone. Over to you.
I think your second question, Nicole, what does it mean for us to achieve USC by 2030? I think it means several things. One is that we need to carry everybody, because I think the reason why you are pushing USC agenda is to ensure that you don't leave people behind. So that's the primary focus of USC. And secondly is to reduce out-of-pocket expenditure, because they are the ones who are contributing to high catastrophic health expenditure. And finally is to have a sustainable financing framework. Over to you, Nicole.
Thank you, Mr. Mushiri and Dr. Hoya. It's exciting to hear about successes that HP Plus and the government have already been able to achieve. And I really appreciated your focus on equity and Kenyans getting value for their money. So Dr. Hoya, I'd like to start with you on this next question. The health sector undertook a comprehensive and prolonged process to develop the Kenya Health Financing Strategy. Given the multi-sectoral scope of the strategy, involving several layers of stakeholders, how did consultations contribute to development?
Yeah, thank you, Nicole. I think you are very right. First, the process was very prolonged and it was multi-sectoral. There was a lot of consultations across different sectors. But what this process actually leveraged on was the issue of having an existing coordination mechanism within the ministry that really helped the process. Here we are talking about the technical working groups and the interagency coordinating committees that actually drive the agenda. And they were instrumental in ensuring that the teams that were discussing Kenya Health Financing Strategy had some common understanding of what issues they wanted to address, like Mr. Mishiri has said. So that coordinating committee came in handy because it's multi-sectoral and it has a wide reach of all sectors and stakeholders. So that is one area where I think we supported, and HP Plus actually had to support that team to come up with the evidence that was able to inform the dialogue within that stakeholder engagement. And the other issue here is about the work that HP Plus did in terms of providing evidence, and that evidence informed most of the discussions. And it was also important to have that evidence because they were now able, the stakeholders were able to discuss from a point of information. And through that, it was easier to reach consensus because it was factual as opposed to hearsay or any other information. The other item is about the devolution, because devolution, as you know, it came in around 2010, but the implementation was in 2013. And implementation brought another layer of stakeholder, which is the county. And through our intervention as HP Plus, we were able to support the interagency coordinating forum, which actually enabled the county governments and the national government to discuss and dialogue around the Kenya Health Financing Strategy. This was important because, as you know, service delivery is now the responsibility of the county governments, which are basically the subnational level. And without their participation, the Kenya Health Financing Strategy would not have been complete without that type of engagement. And of course, HP Plus, together with other donors, notably the World Bank, the JICA, and the WHO, were very instrumental in supporting these intergovernmental forums to ensure that they are facilitated and they also are supported in terms of technical inputs, so that they actually informed the process of Kenya Health Financing Strategy. Over to you, Nicole.
It sounds like a well-coordinated response was essential to finally getting the health financing strategy completed and signed and agreed upon by all these parties. It's a huge effort by the government of Kenya and other country stakeholders. Mr. Mishiri, we've heard a little bit about areas that HP Plus supported through consultations. Can you tell us more about specific areas of the strategy development that HP Plus supported?
Thank you. I think David has covered a bit of this. I just need to expound. One is that on the Interagency Coordinating Committee on Health Financing, I think what we did is that we supported development of a scope of work of that ICC, the composition of it, emphasizing the need for inclusivity so that we have got both public and private sector in it, participation of the private sector so that private sector is able to influence the policy arena, ensuring that we convene the meetings. Sometimes one may take it that for granted, but convening the meetings is a key thing. So we supported that convening of the meetings and guiding deliberations in those discussions and follow up of the actions that are coming from those committees. So that was very, very key. The second area is evidence generation. I think many of them, but I'll probably mention two which were critical to inform the process. One is the National Health Account, which informed how funding is mobilized, how funding is spent, when we are moving towards reducing our reliance on the donor fraternity. And finally, the Household Expenditure and Transaction Survey, which gave us an indication the impact of our interventions to the household in terms of catastrophic health expenditure. Are we improving access? Are we improving equity? Are poor people accessing health? So those two documents were very critical in informing the discussions going forward. And I think you see in the strategy they are heavily quoted in the strategy. And finally, consultation. David has mentioned about this, but consultation was key. Because you needed to bring stakeholders together for them to be able to have consensus on the issues we called gray areas, the areas that were contentious. So we were able to map who supports, who does not support, further engagement, informal and formal, to ensure that at the end of the day, people have got concurrence of some of those issues. So those are the three things that were supported. And I'm happy to say that I think finally, after all that engagement, I think HP Plus was critical in developing the various draft of the strategy. I think the last round, I think I saw the first, second, fourth, and fifth. All those things, HP Plus was very, very involved in the actual drafting of the strategy until conclusion. Over to you, Nicole.
That's great to hear. And hearing more about all of the evidence that informed elements of the strategy and the layers of consultations can give Kenyan citizens the confidence that the strategy is well thought out and well considered by the health sector. Dr. Hoya, looking back, what are some of the key takeaways from the process that Kenya undertook? And how can the health sector capitalize on some of these lessons learned in implementation of the strategy?
Yeah, thank you very much. I think you are right, and what Mr. Mishiri has alluded to around evidence. I think evidence during discussions, as far as we know, was very important, and it really helped in reaching consensus in a timely way, because these stakeholders were coming on the table, but without evidence. So our support, of course, brought in that much needed evidence so that it informed the dialogue. And so one key takeaway message is that evidence is important in this type of engagements. The other issue is about the need for an elaborate and effective stakeholder engagement, because all these stakeholders, of course, come with different varying needs and demands. And it's only through that elaborate engagement with these stakeholders is when you are able to actually build consensus. And the other last item is about having a multi-sectoral approach with a technical working group and ICC that is multi-sectoral in such a way that now the linkages with other sectors is made possible, because the committees or those teams bring in people from different sectors. I think those are the important things that we are able to take away. And just to move on to the lessons that can be used during implementation, as I've mentioned, the need for continuous investment in stakeholder engagement is there, because, stakeholders may actually change positions with time. So it's important to keep engaging them over time, so that making sure that they understand what is it they are pushing for, and also making sure that they understand whatever they have put in the document, so that they are able to explain to their constituencies. And they need to step up multi-sector linkages that leverage different social security sectors. This is important because, remember, health cuts across different sectors. So if you have a strategy that is going to help the country to be able to maybe improve services, it must be broadened in such a way that there are linkages with other sectors, especially the social sectors. And then the lastly is the issue of leveraging existing coordination mechanisms. As I've said at the beginning, the coordinating mechanisms at the ministry were very instrumental, and we believe that using the same coordinating mechanism to implement this strategy will be key, because then we are able to ensure that we are implementing a strategy that is supported by a wide multi-sectoral constituency. I think that's all I wanted to say about that issue. Thank you.
Thank you, Dr. Hoya. Kenya has taken an important step in solidifying a social protection framework, and now moving to implementation. Mr. Mushiri, I'd like to hear from your assessment. What do you consider to be the critical next steps for successful implementation of the strategy? Are there specific challenges that you foresee in its implementation? And if so, how can the health sector overcome these challenges?
Thank you, Nicole. I think there are three parts to your question. The first one is on the next steps. I think, as you know, the strategy is a policy document that has been developed through engagement by donor stakeholders in the health sector. But I think for you to operationalize that, you need what we call the UHC policy. I think that UHC policy need to be approved by both National Assembly and County Assembly. So finalizing that UHC policy for adoption by County and National Assembly is very, very, very critical. So that's the next step that I would think. And as we do that policy, then developing the implementation roadmap, because you cannot operationalize a policy if you don't have an action plan that guides on how you are going to implement. So that is very, very important. The second next step is reforming NHIF, or National Hospital Insurance Fund. Is supposed to be the vehicle for UHC, and so reforming NHIF is critical in the process. I know there are challenges in reforming NHIF. We need political commitment. We need some data on actuarial work. We need a lot of stakeholder engagement, but that is critical for us to be able to take this agenda forward. In terms of challenges, I think several challenges I'll mention here. The first one is the issue of county government acceptance to pull funding. As you know, within the constitution, counties receive their money, and they're supposed to allocate that funding to health. Now telling them that you need to pull back that money to the center would be a big issue. And I think we need to see how we can manage that through engagement. And the resistance of professionals, because one of the things that the strategy hopes is that we are going to move from passive strategic purchasing. I think that calls for a change on how we buy health, and as you know, would be a major radical change, and any radical change needs a lot of consultation with professionals, so that they are able to accept that reform. How we engage those professionals, bodies, labor unions will be critical for us to be able to navigate over that. The third one is private sector assistance, because one of the things that the strategy proposes is the whole issue of increased taxation for health, so you're able to mobilize more domestic resources. And private sector will say that you're making them more competitive, so they'll come fighting that you're actually killing them. So how do we ensure that even as we look for additional taxation, that taxation does not make the private sector uncompetitive? And then finally, as you know, we are going to elections next year. We are going to get a new government, and the new government will be coming with a change on focus. We hope that they still be focused on USC, and they will be focused on implementing the strategy objectives. But you never know, things may change. But our hope is that that will happen. But that will be a challenge. In terms of mitigation, I think I will mention two. One is revitalizing. Realization that USC is a journey. I think if you saw in the initial discussion of USC, people felt that you can be able to achieve USC by 2020, and as HP Plus, we told them it's not doable. We need longer time frame. We shared with them what has happened in Japan, in Germany, in Philippines, in Thailand, and we told them the minimum you can take for you to get to USC at least a coverage of 85% is probably 50 years. So making them sit back and say, this is a journey, let's make those steps. As long as we are making those steps and reforms, we are getting there. It's a big discussion, because normally politicians see the lifespan of their time in office, and having them to appreciate that they need to get beyond their time in office is very important. And of course, finally, is enhanced targeted engagement. As I said, there will be labor unions, there will be, especially teachers have very strong fraternity in this country. There will be the civil servant also very strong. That targeted engagement, so they can appreciate what benefits does that USC bring on the table to them. Okay, because if they don't see benefit to them, they continue resisting. So that targeted intervention, engagement, which is informed by evidence, is very, very important. And we hope that as in the next iteration of HP Plus, I think they should be able to provide a lot of evidence to inform that discussion. Over to you, Nicole.
Thank you, Mr. Mushiri. It sounds like this is just the first big step, and at least Kenya has the health financing strategy as a roadmap for this journey forward. Dr. Hoya and Mr. Mushiri, do you have any other reflections to share with us today?
I think I would request David to go first.
Yes, thanks. So I think I have two things to say about this process. I think there is need to continue socializing this document, especially across many stakeholders and citizens, so that we can continue getting buy-in. Because even as we speak now, some people are still asking what is in the document. So there is need for that socialization of the document, so that everybody understands what this document is all about and what is able to deliver on the table. The second item I want to mention is about the issue of they believe that the Kenya Health Financing Strategy is a panacea for all, a solution to all problems. I think it's important for professionals to understand that it's a blueprint. And being a blueprint, there are certain challenges that may come up as we move along. One of which is just what has hit the world recently, the COVID pandemic. We need to be able now to see how can we refine this strategy to be able to also deal with such like pandemics whenever they occur. I think that those are the two things I wanted to mention about this strategy. Over to you.
I think I probably want to add two things in addition to what David has said. One is that, in Kenya, the owner of money, or in Swahili we call it pesa. The owner of that pesa is national treasury and county treasury. And I think if you look at the initial consultations, I think we didn't engage those two arms, properly. So we need to go back and, re-engage with those two institutions, so that because they are the owners for the money in terms of physical space, so that at least when you go to them and you say you want more money, you want more taxation, they are amenable to your reform. So that is very critical, engaging the owners of the money. The second issue is if you look at the strategy, it assumes that you are going to cover what we call the Kenya Essential Package for Health in the next 4 years. I think we need to really do some actuarial analysis, so you're able to guide the discussion that you can only be able to cover this part of the package, this far, depending on the money that you have. And then as additional funding becomes available, we identify what are those benefits that we need to add so that progressively we are able to, be able to realign funding and the benefit package. In the absence of that, we may probably be ambitious, we may run, and then you find that we are running broke because we cannot be able to cover the package, or we are over-promising. Then people start, coming back to us and saying, why are you causing us to pay and you're not covering the package? I think those are the two issues that I think I would suggest that in terms of need to be addressed, so that we are able to have a well-coordinated implementation of the strategy.
Thank you. Mr. Mushiri and Dr. Hoya, it was a pleasure to have you with us in this engaging interview. Thank you for your time and your important insights on the Kenya Health Financing Strategy development process. We look forward to learning and sharing more as Kenya implements this important strategy.
Thank you very
Nicole.
much.
Bye-bye.
Thank you.
Bye-bye. Bye-bye.